I would just like to say, firstly, that the reason we're doing this webinar today is we are, as a partner with the Ballyfermot Drugs Task Force, Dublin 12 Drugs Task Force, Canal Communities Drugs Task Force and the South Inner City, we're working in a collaborative initiative looking at exploring community alcohol detox. This actually came through funding through a strategic health initiative which was rolled out from the Minister of Health office back in 2019. We kicked off about early 2020 and we're going to be working on this until the end of 2022. What we're really looking at and exploring, I suppose, and doing a lot of collaborative stakeholder and scoping work, is how we can develop an effective and successful model of community alcohol detox for our service users. Within our service here over the past few years, we've been very aware of our limitations and other people's limitations in terms of support around that detox and how important it is. So, as I said, it's an initiative that's it's not new, as we will be hearing from people today who will be talking about how they work their own alcohol detoxes, but we're specifically looking at rolling that out in a community setting across those 4 task force areas. So that's pretty much from me. Just again, at behalf on all of the collaborators in this initiative, I'd like to say thanks for joining us. I hope that you get something out of this in terms of being able to explore within your own role or work how this might be useful for you moving forward. So what I'm going to do now is I'm going to hand over to my colleague, Niamh Foley. Niamh is the alcohol link worker within the Community Alcohol Detox Initiative. She's going to talk a little bit about the work we've done so far and basically what we plan to do before the end of 2022. So thanks very much. Thanks, Niamh.
Thanks, Nicola. Hello everyone, and thank you very much for coming today. So as Nicola said, I'm the alcohol link worker here in Community Response in collaboration with the 4 local drug and alcohol task forces. So I suppose with the Community Alcohol Detox Initiative, the strategic aim is to create a best practice manual that can be used by a variety of stakeholders to support service users with community alcohol detox. And it's also to look at mitigating problem alcohol use within the community across the 4 task force areas. As part of that, we have, I suppose, consulted with a variety of stakeholders in order to inform this manual and to move forward with the manual. So as part of that, we've liaised with service users through questionnaires and interviews. We've also discussed with service providers about their experiences with community alcohol detox and GP involvement as well. So as part of the service user involvement with the questionnaires, we've gotten massive feedback in terms of fear and isolation in terms of accessing community alcohol detox or community supports to help them with their alcohol use, and also maybe a lack of awareness in terms of being signposted to kind of various different services that, you know, there's lots of different services out there, but it's just in terms of getting the right ones to meet their needs. In terms of service providers, we've identified that there are informal protocols out there that community alcohol detox is happening, but there's no set protocols in place. Some services have relationships with GPs and some don't, and it's really about that communication piece with this community alcohol detox that we're seeing in terms of communicating with GPs and services and having a proper continuum approach to communicating. And then in terms of our GP engagement then as well, this consultation has been ongoing for the past number of months and will be ongoing for the next couple of months in order to inform our manual. And with the GP engagement, again, there is a theme coming back that there is a lack of awareness about services and a lack of knowledge of addiction services out there. And again, it goes back to that theme around communicating with each other and trying to get referral pathways set up. As part of that as well, we've looked at strengthening services capacity in order to respond to community alcohol detox. So with that, we've offered key working and care planning support, training for staff across the 4 task force areas. And we have offered motivational interviewing. And over the coming months, then we will be looking at offering more training and workshops in that regard. So going forward, we will be continuing this consultation piece and this will be ongoing in terms of engaging with all the stakeholders involved. And that will be used to liaise with the consultant in order to inform the manual. With the consultation piece, we've also identified clinical and social barriers in terms of service users accessing community supports for their alcohol use, and this will be incorporated by identifying setting up referral pathways between GPs and services to create the best possible outcomes for service users. As part of this, we will be doing service user involvement piece as well in order to get service users' experiences of what's happening right now. And again, like I said, there will be more workshops and trainings going forward. So now I'm going to hand you over. We've done interviews with service users as part of this initiative, and we're going to hand you over now to a video of a service user feedback on their community alcohol detox experience.
I'm 48 years of age. I'm an alcoholic and I've been actively drinking for the last 20 years. Now, it has really taken its toll on me, physically and mentally. I have completed community alcohol detox around 3 times and residential about 14 times. I think what is so important to have a detox in the community is that you still have to face the same problems every day and you are still in the same environment. Sometimes with GPs, they do not realise how desperate we can become. We are stigmatised very much. I often feel once I mention alcohol, you are asked, can you not just stop drinking? Or I feel very much misunderstood. The most encouraging part, my GP said to me, Miss Smith, please come back to me before it is too late. I can see you're trying. It is so important that you keep trying. It made me feel encouraged and that I can trust him and that I'm not stigmatised. The service I go to, oh my God, everyone knows me, everyone knows what I'm going through, and then it is also to be in the group and to hear other people to have the support, the stories they tell over the week. That is so important. Some people relapse and some people progress, and that is the beauty that keeps me going, not to give up. It gives me, if someone else can do it, I can do it.
Thanks for that, and thanks to you, Niamh, for that introduction to the day. It's just important to note that that is an actual service user experience. We just we used voiceover and we anonymised them. It's obviously to protect their own right to privacy. So what we're going to do now is, as we said, that there's components that will hopefully make a successful collaborative community alcohol detox work, and one of the key parts of that is the GP role within that and how it links with the other key partners. So again, we're going to revert to a video which shows Dr. Mark Murphy talking about some of his role and some of his experience. What we're going to do is, that's quite a short video, then we're going to follow up with Niamh doing a live Q&A with Mark following the video. Thanks very much.
My name is Mark. I'm a GP in the South Inner City. Myself and 2 colleagues, we set up a practice called Eldon Family Practice, which is on the South Circular Road. I also work in the North Inner City, looking after homeless patients in a clinic with Dr. Austin O'Carroll. So that revolves around addiction-related problems and also primary care for the homeless populations. Well, as a GP, I'm involved in the kind of delivery of comprehensive, continuous care relating to psychological, social, biomedical healthcare problems. So I think I, as a GP, have a very, I suppose, important kind of perspective in that I see how much harm alcohol causes in our communities, the stigma that relates to alcohol misuse, the fact that we can mitigate our alcohol use and change that course. And a big part of the GP's role, apart from identifying alcohol misuse, is also steering patients away from harmful drinking. As a trusted healthcare professional, we have longitudinal relationships with our patients. So we're there to ask patients about their alcohol consumption, to inquire about whether or not we believe that there is misuse or addiction at play. And then we are also there to I suppose, support patients when they are ready to mitigate excessive alcohol consumption. So we want GPs to be well resourced, and we want patients to have high quality relationships with the same GP. And we also then need, I suppose, an integrated, rapid referral program and link with community psychosocial and addiction supports. And that's really crucial, because that particular professional, that relationship between a GP and that community link worker or professional is really important. And I think that knowing that community resources there will enhance the confidence of a GP, a patient, to have a successful detox. I think the missing piece we need a carefully mapped community psychosocial and addiction kind of resource program. How are patients going to be supported over those 2 weeks? How are their kind of holistic needs, how are their social needs going to be cared for on top of a GP? It can't all be done in general practice. And I think what we really need in Ireland, so in our villages and towns and in our cities, is a carefully mapped community resource. What is in place to help patients, support them through the 2 weeks, and how is that going to, I suppose, springboard the patient onwards to maintain sobriety in the coming months afterwards.
Mark, thank you very much for that video, and it was really insightful, and thanks so much for your collaboration so far with this initiative. So could I ask, as a GP, where do you see your role in identifying and managing alcohol detox in practice?
Yeah, thanks very much. It's always great to hear my own voice on a video and see me speak. But and thanks for inviting me to this webinar. I think the question was, how do I see myself involved in community detox?
Yeah, well, I suppose, where do you see your role, I suppose, in identifying and managing alcohol detox in practice?
Yeah, if I take a step back, I think that GPs, there's an onus on us as GPs and as practice teams and practice nurses to look after the physical, psychological and social health of our patients. So alcohol and alcohol addiction is just one piece for that patient. So I suppose the onus on us is to look after their physical health in terms of, and alcohol can have all sorts of, it's a risk factor for all sorts of other physical health problems, such as one's liver health, their cardiac health, it's a risk factor for cardiac disease. So the onus on us is to look after the physical side and also to point that out. It's also to look at the social harms that can be impacted because of alcohol use and vice versa. Obviously with the homeless and housing crisis and other issues, that can also, with COVID-19, I think a lot of
political and economic stressors push people into alcohol misuse. So it's to look at the social health, and it's also to look at psychological health. So to look at effective anxiety symptoms and also coexistent polysubstance misuse and addiction. So I think it's to be holistic and to try over time, because you can't do everything in 15 minutes, to try and address that. But it's clear that we have a role, just like the speaker, the service user there, to dispel stigma, to provide hope. And I think that service user really said that if they want to stop, we'll be there. When they want to cease their alcohol use, and we'll be there to provide the community detox, and we'll be there afterwards as well. And I suppose it's always there to have an open door and to follow up. So it's really there to have hope and to say that we will be there when you want to engage in an alcohol detox.
Yeah. And I suppose with the practicalities of an alcohol detox in practice, how does that work in your everyday?
I think we have to plan ahead before a community alcohol detox takes place. So we have to kind of think about, it can be potentially hazardous, as we all are aware. The vast majority of alcohol detoxes can take place in the community. However, we do know that particularly on day 3, 4, after, if someone ceases drinking and if they had excessive alcohol consumption, there is a risk of potentially seizures, etc. So you have to kind of possibly risk stratify. Is there a history of seizure disorder? Is there a history of previous delirious tremens? We have to see that there's motivation. we have to see, and I presume we'll talk about this for the rest of the webinar, community resources to support the patient. An alcohol detox with a GP alone is probably not going to work. We need a comprehensive psychosocial support around that, and addiction support leading into group work. So I think once we know that we're ready to go, I think you have to pick the day. So I think Monday, Tuesday, Wednesday are typically good days in general practice to start it. I think it's a good idea to tell the patient that they'll be getting daily dispensing of their Librium or their chlordiazepoxide, that they will have to attend the pharmacy every day. They'll certainly have to attend the GP probably every day for at least 4 days to assess for withdrawal symptoms. So that's another, so practice nurses and GPs can do that, and there's validated scales that we use. And then I think it's kind of to think about a safe environment that also looks after other holistic aspects of their care. So it's not just prescribing the Librium. We will also be considering their nutrition, their weight, thinking about timing, thinking about, do we need to think about other aspects, like if there's polysubstance misuse, do we have to think about other drugs like benzodiazepines, which could impact the detox program? And do we need to do bloods and other things like that? So they'll be coming into the GP probably every few days. We'll do a blood pressure check, a pulse check, see how they are, and crucially see, are they linking in with the community resource? Who are you talking to? What residential programs happened in the past? Do you want to do group work in the future? How are you going to maintain your sobriety? So kind of motivating them and being there all the time, dispelling stigma, providing a bit of hope.
And for, I suppose, any GPs or healthcare workers or professionals that are on this webinar today, like, what would you advise them in terms of taking into consideration how community alcohol detox is being run right now? What kind of conversations should staff be and professionals be having with service users when they come in through the doors?
Yeah, I think we, as I mentioned in that video, I think a missing link is an integration of what's happening in the GP consultation room with the excellent resources that are already existing outside. And obviously we're well aware of kind of LifeRing and AA, but there are so many more resources, social and psychological, specific to addiction, and wider social supports that are out there. And I think it's really important that we explore that psychosocial context with patients. How are they going to get through the detox safely, and how are they going to springboard afterwards? So I think a big part of our role is to articulate that, to verbalize how important it is to engage with, if it's a key worker or a link worker, how are they going to stay motivated and what they're going to do? And that's probably the most important part of the GP, to really platform those resources and say, like, go for it. And you really need to engage in those kind of important community supports.
And I suppose, what do you think then would increase the effectiveness of community alcohol detox in practice across the board, from when somebody comes in looking to, I suppose, reduce their alcohol consumption or cease their alcohol consumption, and then moving forward step by step?
Well, there's a tale of two practices. I work, and at the moment I'm in the Granby this morning in the North Inner City, and we're very lucky to have an Anna Liffey supported key worker next door in the practice. So undoubtedly, because there's no fragmentation of care, those service users who want an alcohol detox can access this wonderful resource. And that's really where the magic of addiction and social support care happens, through that key worker. And the nice thing about being next door, that conversations can happen, and that there's a trusted, I suppose, communication channel between myself and a key worker. Whereas in the other clinic that I work, which is a private general practice, it can be more challenging to have those communication channels. So the first gap, the first most important thing is we need to have a link. And I would say, because I now know you, Niamh, so I know that I can email you and contact you, and you are straight back to me in terms of what resources happen for certain patients who need a resource. So having an open communication where there isn't a barrier, with a trusted key worker or link worker who will contact the patient, that's invaluable. That's the most important missing piece. There's probably, without plugging the problems of general practice too much, there are resource issues in GP. There aren't enough of us. I think our teams and our practice nurses aren't fully supported. We don't have universal healthcare. So for those patients who don't have a medical card, having to pay to see a GP is a barrier. So I think there are understandable resource issues as well. But to be honest, we GPs are willing. It's not every week you'd be starting an alcohol detox. These are our most vulnerable patients. GPs across the board will be willing to commence an alcohol detox for those patients when they want it, as long as we know that there's a community resource. And I think in the South inner city, we're very lucky that we have that through community response. And that's something that needs to be, rolled out nationwide.
Well, and hopefully with the Community Alcohol Detox Initiative, that's something that we can promote, that communication piece. So, Mark, thank you so much for your discussion today. And now I'm going to pass you back over to Nicola.
Absolutely, thanks very much, Mark. And just to say, I think that gave a clear overview from your perspective and, your day-to-day work of, what it's like. And it would very much echo what we've been hearing from the scoping that Niamh mentioned at the start. We've been talking to service providers, talking to service users, basically trying to get that sort of 360-degree picture of what people feel they need. And those points that you touched on about psychosocial support, and also, we would know from our service users here that the outcomes and efficacy with a standalone medical detox, that can be a lonely place to leave someone. So that's where, we have services, and that's why I think these kinds of initiatives that do pull together different providers, different disciplines and different geographical areas can be really, really key in providing the best quality service possible. So thanks, Mark. See you at the end of this webinar on the panel. So now what we're going to do for our last presenter of this webinar is we're going to go to listen to Orla Condren, who works with the Dublin Simon community, and she works overseeing the actual community detox program within Simon. Again, from the learning that we've picked up over the past year or so working on this initiative, we were presented with more practical questions around what a detox actually is in alcohol and what it looks like. More so, I think a lot of services would be more familiar maybe with methadone detox, opiate detox, or to a certain degree benzo detox. So we thought it would be useful, to help our own learning and to help generate learning for the people on the webinar today, to actually take a step back to have a look at the practicalities of detox. So as I said, we have live on the line now. As always, hoping technology will work, fingers crossed. Orla's going to be giving a presentation for us. Orla, thank you so much for your time. You're very welcome.
Thank you very much for having me, and I must say that that's two very difficult speakers to follow. But I am Orla Condren, and I'm the clinical nurse manager in the Dublin Simon Detox. So what we actually do is residential, and it is all working with homeless people. So I've been managing that unit for just over 4 years now. And I suppose during that period of time, what we have experienced is there's been a huge shift in the demographic of the people we're seeing. So historically, we would have been doing alcohol detoxes, but because people are just using much more polysubstances, we are now doing everything from benzodiazepine detoxes. So benzos and alcohol would be our principal work, but we do accept people who are using cocaine, heroin, and all that goes with that. So we also do methadone titrations to try and get people down to levels that they're able to access further treatment. So I'll move on to my next slide now. So I suppose, as has been pointed out by previous speakers, there is huge risks with an alcohol or a benzodiazepine detox. The risks with alcohol are predominantly within the first 72 hours, but unfortunately with benzos, that risk period increases up to about 3 weeks. And the main risks that we would be looking at are seizures, cardiac events, strokes, gastrointestinal bleeds, and suicide. They would be the main ones that we would kind of see early on. So what we would do is we bring them in, we start them on their Librium, and as has been mentioned before, we go with thiamine and lansoprazole, and we would monitor them very clearly for signs of withdrawal, which I won't go through all of them, they're there on the slide, but we would measure that in relation to a CUS score. And if the CUS score is increasing, we would give people intermittent doses of Librium as well to ensure that they're safe within the unit. I suppose one of the big issues that we would deal with is benzo detoxes can be quite difficult because we can't measure levels of benzos. So we don't actually know what people are using, and we're taking what they're telling us at face value. So what we need to do with that is just hope that they're telling us the truth and ensure that we're covering them with enough Librium to manage the withdrawals that they might experience. Because if they're taking huge levels of street benzos and we can only give them certain amounts of Librium, we may not be able to manage that process, and they are at a higher risk. A benzo detox is also a lot slower than an alcohol detox. So the alcohol detox would titrate quite quickly. It takes about 11 to 12 days, whereas a benzo detox can take anything up to 25 to 30 days, depending on what the person was using and how much alcohol they were using on top of that. So I'll move on to my next slide. So I suppose when it comes to detoxing, not everybody can be detoxed in a community setting. And I think there's a number of things that we as professionals need to really take into consideration when we're deciding what route is needed for somebody to complete successfully a detox. And a lot of that has been discussed earlier on as well. So I suppose the first thing is, what is the client detoxing from? Are they maintenance drinking, or are they just drinking in the evenings? You know, how much benzos are they using? Is it going to be safe? Have they had complicated detoxes in the past, including withdrawal-related seizures and that kind of thing? So is there a risk that the client might use other substances whilst completing a community detox? Is there anyone to monitor them in the first 72 hours to check for the risks that I have mentioned before? I suppose for me, the clients that I work with are all homeless. And I suppose that poses its own problems. If they are completing a community detox, can they be monitored in a hostel? Are they safe on the street with Librium? Is there a chance that they will drink on top of the Librium that they've been given? So that's why we have them in the residential setting, and it's all nurse-led and they are monitored. Has the client got a support network is a very big one. It's the basic things in the first 72 hours, things like being able to have access to food and, you know, to water, are they able to get to their clinics? That's a big one in the first 72 hours. And then the other thing that has been touched on very well by the other speakers is, what is the follow-up plan for this person? What are the supports that they're going to get? So what we do within the detox unit is, it is a full program. After the first 72 hours, clients are expected to attend 4 groups a day. So there'd be a morning group to plan the day, and then there's 2 groups during the day which cover everything from financial planning to relationships to triggers and cravings, all of that aspect of addiction. And then there's an evening group to see how their day had gone and did they achieve their goals that day. We also encourage things like journaling and that kind of thing for clients to ensure that they're mapping their own progress and seeing how well they are doing. During the time they're in, they also link with a key worker, and we discuss with them what they want as a follow-on. So that could be that they move on to the Dublin-Simon recovery program, or some people want to go back to where they've come from. They don't want to move on to further treatment. And for other people, we also link in with places like Merchants Quay, actually, who are great. So we would get people into Francis Farm, or we'd get people into Hyde Park or Cool Mine as well, if we felt that they needed a more structured recovery process. So sometimes to do that, a barrier is the methadone. If somebody comes in and they're on more than 50 mils of methadone, we will work with them to get them down to the 50 mils or below so that they can actually access these external structures. So that's a brief overview of what we do, but I would just like to say I very much agree with what the other speakers have said. There is so much stigma attached to the clients that we work with, you know, and it's so hard for them to take that step and to actually start a detox. So when they do come in, it is all about dignity and respect and helping them where they're at that point of time, rather than having kind of the paternalistic, well, this is what I think you should do. So I think if we can start off on that vein, we do quite well with the clients. Thank you very much, and I'll hand you back to Nicola.
That's absolutely perfect. Thanks a million, Ola. That was really, really useful. I was actually thinking about certain situations as you were talking about how complex, how many facets there are to embarking on a detox, and about how, I suppose, when you review that and you listen to all the considerations, risk assessment, and planning that's done, you know, within your environment, that the idea that we could, you know, expect an individual to effectively, you know, walk away with a script and manage a lot of that themselves without medical or psychosocial supporting it would be incredibly challenging. So yeah, I think really important there, and I think you echoed a lot of points that the previous speakers have as well about the importance of aftercare and what's going to happen next with people. I think it's key. But look, once again, Ola, thank you so much for your time. We're literally, if you just hold your breath for a couple of minutes, we're going to have a short service user video and then come back in for the questions and answers. But thanks again, Ola, that was excellent.
Thank you.
So as I said, we're kind of bookending today's webinar with what we think is very important, which is the service user input aspect. So we began with the, as I said, the real voices of a service user, and we're ending with the same, although obviously it's anonymized to protect their own right to privacy. So we're going to finish up with feedback from a male service user and their experience of maybe not just alcohol detox, but the broader alcohol service and support that was available to them. So we're going to take that now.
My name is Joe. I'm 55 years of age. I'm from Ireland. I was living abroad for 20 years and had a wife and a well-paid job and a home. Now I'm separated, and my drinking happened after I came home because of my marriage and whatever. It was 2017 and I was admitted into a hospital ward specifically for alcohol and drug users. Thinking back to that hospital experience, it was very harrowing and scary. And I was facing homelessness. A couple of weeks after being made homeless, I ended up back in the hospital on a detox. And I was on Librium. Only this time when they released me, I was given a psychiatrist and a social worker in my local medical centre. My psychiatrist gave me the number for a local addiction service, and I never rang it. At the time, I was staying in homeless accommodation, and it was very quickly in that environment that I realised that I'm not going to survive here. It was after that realisation, through my medical centre, I got in contact with a local service that offers support around addiction. It was the best decision I ever made in years. I just had one slip during this time, and it was through this organisation I got back to where I was. Through my key workers and the group support and just listening to other people and discussing the physical effects and mental damage that alcohol can have, and all that combined, it just really instilled in me, right, there's no going back now. I think if someone was looking for support to help them with their alcohol use now, I think you'd have to get a GP to refer you, because anyone who uses drink or drugs, there's a backstory to all of this usage, you know. You can't do it on your own. I definitely think that medical help and counselling, and you need peer groups, that's very important actually. I think it's a combination of group meetings and mindfulness and meeting your key workers. You need to get involved and go to as many people as possible. I don't know where I would be if it wasn't for the service I link in with.
Thanks and welcome back, everyone. Just before we move on, we're quite on time, so we've got time for some questions and answers. Just a reminder, you can either do that, it's probably the best way at this stage is to use the chat, maybe just to type your name in and say you have a question, and we can unmute you, or you can unmute yourself so you can ask of one of the panel. The other thing is you can raise your hand as well, but I'm not quite sure whether we'll see that, so maybe it's best to stick with the chat. I just wanted to make a point that this week is actually European Alcohol Awareness Week. It's one of the reasons that we chose this date for this event. And there's a few things happening obviously around Europe and also online about information about alcohol support, issues with alcohol. I also know that the HSE have a webinar on tomorrow afternoon. I think it's to do with alcohol and brain injury, if I'm right, but it's 3 o'clock tomorrow afternoon anyway. But I would say if you're looking for more information about anything else you'd like to pick up on this week, go to either our website, www.communityresponse.ie, or the HSE askaboutAlcohol.ie site. So just to say that. So I'm going to allow as much time as we can for questions and answers. So basically, I'm just going to open it up. And as I said, if you come in with a question on the chat and just basically say you have a question, we can make contact that way. Okay. So if we have, do we have access to the panel now? Can they hear us? Because we have a question here we have a couple of questions. Okay, the first one we have is Audrey, and it's a question for Mark. And it's asking, Mark, what success do you see in practice with community alcohol detox? So that's for you there, Mark.
Thanks. That's the question, Audrey. I think in the Granby, where I think the population in the North Inner City, there's a significant burden of illness, which is, predominantly politically mediated. There are an awful lot of people who are homeless and living in hostels, and I think they turn to substances and alcohol and other drugs, particularly benzodiazepines, are widely misused in the population of patients we see. And I think in that setting, with an excellent resource with the Anna Liffey drug worker in the Granby, there are successes. Clearly, I think addiction is a relapsing illness, and we're there to bear witness to the problems patients have and be there when a relapse happens. But there are successes, not just in maintaining sobriety, but reducing the level of alcohol intake, increasing the time between relapses, mitigating the other physical harms of and reducing the amount of alcohol that certain patients take. In general practice, I would say my experience is that without significant community resources and addiction kind of supports around general practices, that I think detoxes fail. And I think that's just a reality. And I think that's an historical legacy, but it's up to us to kind of do better, to make sure that important link workers are there to work with patients and guide them to the psychological and social supports that they need. So it's mixed, the results that I see. And I think it's contingent on what type of supports are around are around the patient when they access the healthcare service, whether that's the GP or the emergency department. We need resources where patients see the healthcare services, and we need to build it from there.
Great, thanks very much, Mark. Very clear response to that. And obviously, yeah, the outcome depends on what's present at the time. I think that's coming through really strongly. And thanks for the question, Audrey. So I'm just going to move on to the next question, which is from Barbara. And this seems to be to anyone on the panel who wants to take it, is how can clients with a language barrier avail of this service? I suppose by that they're meaning an alcohol detox. Neve, you're muted there. Can we unmute you at this end? Oh, sorry, Orla. You're Neve on my screen, Orla.
About that, sorry. So yeah, but I could take that. The language barrier piece is a huge issue, and it's very difficult to get translators, etc. However, you can actually work with people with language barriers. We would probably have 2 to 3 non-Irish people in at any given point of time, and a lot of them don't speak great English at all. And what we would do is try and get them through the program as best as possible, and then get them into the recovery program and actually into English classes. So once you actually get them sobered up, you can then move them on and support them around their English, which then feeds into their more long-term sobriety. So we would have gotten a number of clients through that way.
Okay, anything else from anyone else on the language barriers?
I might just come in on that. I think that, as Orla said, it is a barrier, and however, we still, like all healthcare interactions and all acute and chronic care that happens in general practice and emergency departments, we still just have to act in front of us. And I think we can use Google Translate. We can use, sometimes it's not ideal, but we can use peers and family and support workers. And there are trusted peers that often, and friends that often support non-nationals who do not speak English. And I think it's not ideal, but we can work around it. And I think, look, working in Irish healthcare, you have to be practical. Things aren't perfect. And I mean, that's why we're here, because there isn't really a historical legacy of having integrated primary care where all stakeholders are talking together in a cohesive manner. And I think just like that, it's the same thing with patients who do not speak English. In a perfect world, we would have translators, but we just have to kind of get on with it. And I think we can, although it's not perfect.
Absolutely. Thanks for that, Mark. I couldn't agree more. I think sometimes it's about, using what we have and using that more effectively than always trying to say, we need something very specific for every step of the way. With our population, that probably isn't feasible. I have a question from Kevin here in St. James's. So really, he's actually looking to link in around this initiative, which is absolutely excellent. Someone will be in touch with you, Kevin. He also makes a point at the end to say, the last video from the service user certainly speaks to the level of difficulty our patients are often facing and the complexities that exist in care planning appropriately. Okay, so I'm asking a question now out to the panel from Deirdre, who is asking if pregnant women can be included and attend a community alcohol detox. So maybe either Orla or Mark for that one.
Yeah, sorry. Okay, I can answer that as well. Yes, we do include pregnant women in our services. Often, I suppose something that hasn't been mentioned, what we do tend to find, particularly within the homeless population, is that women in general tend to have more trauma than men and tend to be more complex to deal with. What my experience would be is that we have less success with our female client group than our male client group, just by nature of their background and the trauma that they've been through. but we definitely do include pregnant women and have had pregnant women within our services.
That's great news to hear that as well, about a gender-specific service. I'm going to ask if we could stop with any new questions at this point, because I know we're not going to get time to ask them. We've still got another 3 or 4 to get through in the time that we have. So the next question is Hugh, who's from a group of GPs in a practice, was wondering what is the best way to refer patients to community response from general practice. Hugh, we can follow up with that individually with you after, although I think I mentioned our website earlier, there is a referral form on that. Another question here from La. He's asking, does the service user need a medical card or is it a free service for all? So I guess basically, if you have a medical card, can you avail of it, maybe he means, and if not, do you have to pay?
I think, you know, like this is a kind of a little bit of a political question in a way. I think GPs are, we are burdened by a significant amount of workload at the moment in COVID-19. I worked 14 hours yesterday. Like they're long days and we are stressed. And I know we can all feel that. If you call a GP, there's a waiting list, right? When can you see the GP? You know, if you want to have a continuous relationship with the GP, who you want to see. So within that context, we have to be practical and real. I think that GPs are very much aware that if someone is willing and engaged and there are community resources there to support a patient, and a patient wants to engage in a detox and wants all good to go for next Monday, that space will be made available. And I think we can talk about whether or not this is covered under the medical card. If it's a private patient, I'd imagine they'd have to pay. But in general, for these patients, we're probably talking about medical card patients because of the social and economic kind of burdens and adverse events that often fall on people. But obviously, addiction is not class focused only, and anyone can have alcohol dependency. But for a medical card patient, I would assume and like to think that almost all patients will be covered and accommodated by GPs, particularly knowing that there is a community response and resource. So I think there shouldn't be an anxiety there. If people want to access care, GPs will step up and do that.
That's fantastic. Thanks very much, Mark. Very comprehensive answer to a tricky enough question. Another question here from Sinead, who is saying, basically, I'm wondering if people are linked in with AA and NA, that many people have found the fellowship's essential in maintaining long-term sobriety. I think I'll actually just take that one, Sinead. I think Mark mentioned in his presentation about the use and the referrals for Life Ring, Smart Recovery. You know, there's lots of options there. And I don't think anyone who is either on the edges or directly involved in working with addiction would have any hesitation with broadening the net as much as possible for supports for individuals. And if I'm right, I just want to double check so I don't leave anyone out. No, that's fine. That's for it on the questions. So basically, it's just left for me to once again thank Sanjay, Mark, and Ola for their contributions today. And I think it's important to note, as you just said there, Mark, people are busy. People who are working in medicine or marginalised services, or basically pretty much any service at the moment, are really, really busy. So we genuinely really appreciate the time that you gave up to do this and participate in this today. We think it's an important initiative, as I mentioned at the start. It's across 4 task forces from Ballyfermot across to the south inner city, the canal communities and D12. And we really, that's a big population when you look at it. And it's, you know, it's an ambitious project, but it's something that we believe there's a lot of resources there that, you know, people have talked about them here today, that can be utilised, that can be brought together, and what we have can be used more effectively. If you want to know more about this project, go to the social media of any of those task forces or come onto the Community Response website. As I said, we will be working on this until the end of 2022 with the view to piloting it probably from April, May onwards next year, when we've got all of our background work, scoping and stakeholder mapping built into that. So I just want to say thanks for the time. Thanks for signing in, and take care of yourselves. Bye now.